All right. So, fits, fall, loss of consciousness, vertigo, dizziness. You need to take history in three parts: before, during, and after. So, what are the questions you can ask during? So, the question that you're going to ask in during would be, if it's a fit, you'll ask for the duration of the fit, how long the fit lasted. You'll ask if the fit was generalized or localized. So, that's really important. Localized or generalized. You'll ask about tongue biting, uprolling of eyes, and urine or stool incontinence. So, duration of the fit, if it is generalized or localized, if there are any uprolling of eyes, tongue biting, urine or stool incontinence. The thing is, if you are talking to a patient, your patient might not be able to give these answers because if somebody had the fit, how they can tell for how long it lasted, whether there was any uprolling of eyes, they might not be able to tell. Should I ask these questions to my patient or not? Yes, I will ask. You'll ask the question, you may not get the answer. You may get the answer maybe because somebody has witnessed the fit. There is no harm in asking, right? So ask. So this is how you will elaborate the thing. Then you will ask if there was any loss of consciousness. If they say yes, what you do? You ask for how long, duration of the fit. If the presenting complaint is loss of consciousness, you will ask, you'll elaborate it, you'll ask for how long the loss of consciousness lasts. Doctor, half an hour. Okay. Was there any fit? Yes, you go in detail. Fit? No, you move on to after. If there is a fall, you ask during the fall if you had any jerky movement. Yes, go in detail. Go in detail of it. No, you move on. So this is what you need to do. How were you feeling after the episode of fit? How were you feeling after the episode of fall? How were you feeling after the episode of loss of consciousness? How were you feeling after the episode of vertigo or dizziness? After. So what are you interested in? Whether the patient was confused, whether the patient was sleepy, whether the patient was drowsy, whether there was any kind of nausea, whether there was any kind of vomiting, any trauma, injury, or amnesia. What is amnesia? What is retro and anterograde amnesia? Anterograde is after the event. Retrograde is before the event. Anterograde is after AA. A anterograde, A is after the event. These are, my friend, fixed questions that you need to ask in a patient who's coming to you with fits, fall, loss of consciousness, vertigo, or dizziness. Straight questions during and after. Then what you need to do, you need to ask the patient about before. You will ask the before. In before, what are you trying to do? You're trying to find out the reason of fit, reason of fall, reason of loss of consciousness, vertigo, or dizziness. That is the main thing, right? Now, what are the causes of fall? Let's put it this way. Let's make it easy for you. Causes of fall. There are n number of causes, isn't it? I'll try to put it in a way so it is gonna stay in your mind and you'll never forget. Trust me. So we have got medical causes of fall. We have got non-medical causes of fall, or non-medical, I mean environmental causes of fall. And then we have got lifestyle causes of fall. Yeah. So medical causes, let's put it in a way. Can I say diabetes is the cause of fall? Yes. So if you have got, say, hypoglycemia, that can be a reason of fall. Quite possible. Can I say high blood pressure is the cause of fall? Yes. Of course, if I say postural hypotension, that could be the reason of fall as well. Can I say heart problem? Of course, why not? So patient can have, for example, heart block. Patient can have arrhythmias as well. That could be the cause of fall. Yeah. Can I say infection? Yes. So elderly patient, if you've got UTI, you have got pneumonia, that can actually patient go in delirium and can have fall. Yeah. Now, can I say eye problem? Of course. So if you've got loss of vision, blurring of vision, that can be the region of fall, right? Another thing, can I say ear problem? Yes, because ear controls your balance. So any problem usually with the inner ear, you can have fall. So easy way to remember. So infections, diabetes, high blood pressure, heart problem, eye problem, ear problem, that can be the cause of fall. In terms of environmental, I would say not having enough light in the house could be a reason. Another is slippery floors. Another is loose rugs or carpets as well. Yeah. Lifestyle, I would say maybe alcohol, maybe drugs. Yeah. Another thing, if I have to say, I would say age is a reason of fall as well. So, I mean, elderly patient, they have got weak muscles and bones. So that could be the reason of fall as well, right? So, I mean, there are a number of causes of fall, but with this much of information, I try to simplify it for you guys. Because during and after, the history is going to remain the same. This is what you need to do in during and after. But what are you going to do in before? So that is the main thing here, right? So you ask the question. So fit, fall, loss of consciousness. So you have got these differentials here. So what are the questions that you're going to ask? If you think your diagnosis could be encephalitis or meningitis, what do you think patient is going to have before the fit or before the fall or before the loss of consciousness? Can I say I'm expecting my patient might be having a fever, might be having a headache, isn't it? So that is the main thing. Or maybe my patient is having rash as well. Later on, I can ask, maybe I get Brudzinski or Kernick sign positive as well. Yeah. So after I cover this during and after part, what I'm going to do, I'll ask the patient, how are you feeling before the fit, before the fall, before the loss of consciousness, whether you are having any fever, any headache, any rash, any neck stiffness. So that is going to give me the diagnosis. All right. If I'm thinking about epilepsy, what I'll ask, I can ask about the trigger factors. I'll ask very simple question. What were you doing? I want to know where the patient was when he got this fit. So epilepsy, the triggers. To remember the trigger for epilepsy, what you need to know is just remember one thing. You are in a party. So in a party, what you have? You have got flashing of light. You have got loud music. Maybe drinking alcohol that can lead to dehydration, then drugs, skipping meals, even lack of sleep. All these are the trigger factors. So just remember one thing, you are in a party, and in the party, there are all the trigger factors for epilepsy, right? So stroke or TIA, what are the questions that I can ask? I'll ask for fast symptoms. Yeah, you remember? Facial drooping, arm weakness, slurred speech, and there's a time to call. So that's what I can ask. Within 24 hours, if patient symptoms are improving and there are no residual weakness, it's going towards TIA. Patient still having symptoms, that is stroke. SOL, I think we discussed that. So what's going to happen in this? Patient will have number one in before. What I can ask? Any morning headache? Any nausea, vomiting, and any weakness in any part of the body. See, SOL, the symptoms depends on where this lesion is, space occupying lesion. So where exactly it's going to be in my head. Depending on the location, patient can have symptoms as well. All right. Then this head injury is a head injury. Postural hypertension, if the patient is taking any medication for high blood pressure, or if we have make the any recent changes in the medication or not. That could be one of the very important things. Hypoglycemia. Maybe my patient is taking insulin. That could be important. Recreational drugs and alcohol, obviously. Eye and ear problem. Yeah, I'm going to talk about ENT problems in detail. And then, as I said, some environmental factors as well. So maybe slippery floors and loose rugs or carpets or not having enough light in the house can be the cause of fall as well, right? So that is really important. Now we come to vertigo. What is vertigo, first of all? What is vertigo? What is true vertigo? True vertigo is spinning of the room. That is true vertigo. Whenever patient says, I'm having this vertigo, doctor, I'm feeling dizzy, what you have to do is you ask the patient, what do you mean by dizzy? What do you mean by this? This is something you need to ask. Then the patient will tell you, I feel like the spinning of the room. Spinning of the room is true vertigo. Spinning of the room is true vertigo, right? But sometimes patient says, I'm having dizziness. When you ask, tell me more about it, they say, I feel lightheaded. Lightheadedness is not true vertigo. If the patient says lightheadedness, you have to think about postural hypotension. I'll give you a couple of mnemonics as well. So let's write the mnemonics here. So if the patient says, I'm feeling lightheadedness, when they say dizziness, when you elaborate and they say it's lightheadedness, please think about postural hypotension. I'll give you a couple of mnemonics. So that's number one. I'll come back to this. Now, vestibular neuritis. What are the things you have got? Let's see. First of all, whenever you're dealing with ENT problems, ear, there are a fixed number of questions that you need to ask. Accordingly, what is positive, what is negative, you will be able to get these diagnoses, whether it is vestibular neuritis, labyrinthitis, BPPV, Meniere's, or acoustic neuro. First of all, let's see what are these questions I'm going to talk about. So, any ear station, ask these questions. Number one, pain in the ear. Number two, discharge. Number three is the fever, just to see if there is any infection or not. Then obviously I'm dealing with ear, so I have to ask for hearing problem. What else I have to ask? I have to ask for tinnitus, that is ringing sensation. I have to ask for oral fullness. I definitely have to ask for vertigo or dizziness. You have to ask for numbness on face. You have to ask for double vision. You have to ask for nausea, vomiting. I just remember these questions. These are the questions that you need to ask in any ear case. Now, vestibular neuritis. What's going to happen? Vestibular neuritis starts from V. It is a mixture of 3V. In vestibular neuritis, what you have got? You have got vertigo, plus you have got viral infection. Yeah, that's your fever. And then what else? It has got vomiting. That's it. So you ask all these questions. Do you have, so if patient is having vertigo, what I'm going to do in terms of my history, what I will ask if the patient is having vertigo, I'll ask what kind of it is. Is it room is spinning or you feel like lightheaded? Doctor, I feel like room is spinning. Okay, fine. I will ask whether you had any jerky movement. No, doctor. This spinning of the room, how long it lasts? Doctor, it's for few hours. Okay. Fit? No, doctor. Any fall? No, doctor. Any loss of consciousness? No, doctor. After the episode or during the episode, do you feel confused, sleepy, or drowsy? Do you feel any nausea, vomiting, or any trauma? Do you remember things what happened before or after this dizziness? Yes, doctor. Okay, fine. I mean, after covering during and after, you will come for before. So in before, you can ask whether the patient was having any viral infection or not, like any fever, flu-like symptom. Nausea, vomiting, I've already asked in the after. Ask all these questions. Any pain in the ear? No, doctor. Any discharge coming? No, doctor. Fever? Yes, doctor. Hearing problem? No, doctor. Ringing sensation in the ear? No, doctor. Oral fullness? No, doctor. Vertigo, dizziness, that is there as my presenting complaint. Numbness on the face? Numbness on the face? No, doctor. Double vision? No, doctor. What is it? It is vestibular neuritis. What I mean to say is you just need to ask these fixed number of questions. In vestibular neuritis, you will have only three V's in it. You'll have vertigo, you'll have true vertigo, which is spinning of the room. Number two, you will have viral infection. Patient will give you the past medical history of fever, flu-like symptoms. Number three, this patient will have severe nausea, vomiting. Now, will this patient have hearing loss? No. Will they have any tinnitus? No. Oral fullness? No. Any numbness on the face? No. Any double vision? No, 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 no. That is your vestibular neuritis. With all these vestibular neuritis symptoms, if you have got hearing loss, this is labyrinthitis. This is labyrinthitis. Vestibular neuritis plus hearing loss is labyrinthitis. That is it. All right. For vestibular neuritis and labyrinthitis, you don't have to do much. The treatment is symptomatic. Patient is going to get better on its own. It's just you have to encourage the patient that you have this vertigo, so you can go out with somebody, maybe somebody can accompany you in the beginning and slowly get the confidence. We can give you the symptomatic treatment, we can give you something for your vertigo, something for your vomiting, something for your fever. That's absolutely okay, right? And make sure this patient is not dehydrated, and that's it. That's the treatment, nothing much. Yeah. What about BPPV? What's going to happen with BPPV? It will have only vertigo that lasts for few seconds only, right? When they suddenly change their position. So they're lying down and then all of a sudden they stand up, they can have vertigo, which is BPPV. Now, will they have other symptom? Will they have fever, flu-like symptom? No. Will they have hearing problem? No. Tinnitus? No. Oral fullness? No. Numbness on the face? No. Double vision? No. Will they have nausea, vomiting? See, any vertigo patient can have nausea, vomiting. So they will have just this vertigo that is soon after they change the position, and they might have nausea, vomiting as well. Vestibular neuritis or labyrinthitis. This vertigo lasts for few hours to few days. Few hours to few days. Whereas in BPPV, the vertigo lasts for few seconds only. I mean, if you're just elaborating the presenting complaint, guys, you will have your diagnosis with you, right? Rest of the symptoms, when you ask, everything is going to be negative. Any question? No, 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 no. To confirm BPPV, I would like to do general physical examination, vitals, neurological examination, and say one more word. I would like to do Dix-Hellpike maneuver. Dix-Hellpike. So then your dear examiner might give you the finding that it is positive. And the treatment, you know, it is Apley's maneuver. That's it. Again, you're not supposed to do Apley's maneuver here. You just mention about Apley's maneuver. That is it. Okay. What is Meniere's? Meniere's, there is a mnemonic D, V, T. What is D? D is deafness. V is vertigo. And T is tinnitus. Plus, patient can have oral fullness as well. So deafness, vertigo, tinnitus, and oral fullness. That is your Meniere's. Yeah. What is acoustic neuroma? All the Meniere sign plus signs of cranial nerve involvement, like numbness on the face, eye problem, double vision, that is going more towards acoustic neuroma. That's it, right? That is acoustic neuroma. Okay, so vestibular neuritis lasting, the vertigo is true vertigo, lasts for few hours to few days. Same with labyrinthitis as well. In vestibular neuritis, I get three V's: vertigo, true vertigo, viral infection, and vomiting. With these three V, if I get hearing loss as well, that is labyrinthitis. In BPPV, vertigo lasts for a few seconds when I change the head position. And there might be some nausea, vomiting. Rest of all these symptoms are no, 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 no. Meniere's, again, the vertigo lasts for a few hours, and the mnemonic is DVT, deafness, vertigo, and tinnitus. Patient might have oral fullness as well. With all the signs of Meniere's, plus if you have got cranial nerve involvement as well, it's going towards acoustic neuroma. Now I have to give you a few mnemonics as well. First is, if the patient says lightheadedness, you think about postural hypotension. If you have got elderly patient with sensory neural hearing loss and balance problem. What is it? This is acoustic neuroma unless proven otherwise. Number 3, if your patient has got unilateral tinnitus. Guys, unilateral tinnitus is a red flag sign. If you find a patient is having unilateral tinnitus, please investigate for acoustic neuroma. Please investigate for acoustic neuroma. Vestibular neuritis. We have got three V's. What are those? Vertigo, viral infection, vomiting. What is labyrinthitis? Labyrinthitis is vestibular neuritis plus hearing loss. That's it. If you can remember this much, this ENT and lots of problem in ear is just gonna be solved, right? Acoustic neuroma, how are you gonna investigate? Investigation would be, you have to do an MRI, and if you find this SOL, space occupying lesion, acoustic neuroma, which is a benign lesion, so if it is giving symptoms to the patient, you have to take it out by doing the surgery, right? And patient might ask you in acoustic neuroma, if I'm gonna get my hearing back, it's less likely you'll get the hearing back. But what we can give is, we can give hearing aids to the patient for the management. So that's something that you can do. All right. And for Meniere's, this tinnitus, there are some retraction techniques and counseling that can be done. Otherwise, nothing much you can do in terms of this tinnitus. But these mnemonics, whatever I have given, there is a station on that in the exam. That's why I've given it to you. So the patient says lightheadedness. Patient is saying I'm feeling dizzy, but then patient is describing it as lightheadedness. Think about postural hypotension. If patient is elderly patient having sensory neural hearing loss, elderly patient, sensory neural hearing loss, and balance problem, think about acoustic neuroma. If your patient has got unilateral tinnitus, please investigate for acoustic neuroma, do a MRI scan. If the patient having vertigo lasts for a few hours, viral infection, fever, vomiting, think about vestibular neuritis. And if patient has got vestibular neuritis plus hearing loss as well, it's going more towards labyrinthitis. Right? So how are you going to take history and all? It's very easy. You have to go into three parts. You have got to go in during and after. Fixed questions. And then you will come in before. How are you feeling before this? So you need to come back to that. And that's how you're going to get your diagnosis. Right? So if you're able to cover this slide, life is going to be pretty easy. Straightforward. Right. All right.